RCT paper, but it's a cross trial of 3 important trials, TAPA-HF, Paradigm-HF, and the emphasis with the MRA. So we compare the patient that what we have often do is we usually slowly up titrate the patient before we go to the next thing. And in this clinical trial, cross trial, it use a computer to analyze all the data key in. And what is shown is that if you compare a conventional and a comprehensive therapy, which means a more aggressive form of therapy, you're able to show a substantial reduction in CV death and heart failure hospitalization. Individually, you're also able to reduce the CV death, heart failure hospitalization, and all-cause mortality. So how does this translate into a patient? So in this algorithm, they key into a patient of 65 years old heart failure patient, and what they found if you start all these medication upfront for a patient with 65 years old, and the amount of the year that this patient is able to survive is 6.3 years more compared to patient that has been receiving a conventional therapy, which means you slowly up titrate. So this is a 65-year-old patient. You treat a different aspect. A patient with more aggressive form, you start 4 quadruple therapy upfront, and compared to those patients that receive a conventional therapy, by the end of the day, you earn a 6.3 years more. So I think this is a very important point to think about it. Is not to ask you to implement this guideline right now, but I think this is a very important point for us to consider how should we treat our patient. And one of the main reasons because all these agents is belong to different group. It is not belong to the same group. So that's why I think there is no harm, and in fact we should always consider to start the medication that able to target all different class, right?
I think it's really important in terms of giving the treatment heart failure patient. Of course, we've got plenty of medication on board, but please bear in mind all the medication come with side effects.
Yes, absolutely.
Yeah, so be safe in prescribing medications, but go aggressive. As so long the patients can tolerate the dose, tolerate the medication, we go all out.
Yes, I agree. Good paper that you bring up, Dr. Patrick. Yes, new for me actually. That's why I said Dr. Patrick, Dr. Shafiq is the best person for me to discuss about heart failure related semua. And we got a few times. I got go to the second question. This question asks, I have a heart failure reduced infection whose BP is too low to be on Entresto. Quite popular question, I think. It's non-diabetic. Will you start on empagliflozin based on the evidence from Emperor reduced trial? Shafiq, what do you think?
Okay, so just to remind you guys again, the SGLT2, the empagliflozin is not in the guideline yet for the treatment of heart failure. But let's say in the future is being incorporated in the guideline. Yep, I would use the empagliflozin for this patient with HFrEF if they not be able to be Entresto. If you remember from my slides, whether the patient already on Entresto or not yet on an Entresto, the group on empagliflozin, the patient favor, the outcome favor those on the empagliflozin.
I think if you look back at the question, I think this is the best patient for you to consider such SGLT2. Like what Shafiq has clearly mentioned, all these medication, they do have effect of bringing down your blood pressure. So if this patient, you have problem with up titrate your other RAS or beta blocker, and this patient despite of non-diabetic, because now we have 2 clinical trial, RCT trial to show the positive outcome to treat the patient with non-diabetic patient with heart failure. So like what Shafiq rightly mentioned, it was not in the major guideline yet. But I think in earlier this year, Canadian guideline 2020 is advocate to use of SGLT2, but it was because based on a TAPA-HF trial. So it advocate TAPA-glyphosine can be considered to use a patient to treat heart failure without diabetes. But more so, I think now with all this Emperor reduced, I believe in 2021 or 2022, there will be many guidelines will be revised. So perhaps I think it's a very, very exciting thing to think about it.
That right? I think what we're going to expect in the future.
If we do not have resistance from other specialty, but I believe this is a very exciting agent.
Okay, I'll go to the third question. So how do I select which SGLT2 for my patient if I have a patient with heart failure and diabetes and record of CVD, and what are advantage of one of SGLT2 have over the other and vice versa? Oh, I think this is open question for anyone try first.
Yeah, I can try answer this question. So far that we know we have DAPA-HF for dapagliflozin and Emperor reduced for empagliflozin. So both medications showed good outcome in terms of treatment patient, whether they're diabetic or non-diabetic with regard to HFrEF. So if you ask me advantages of SGLT1 over the other, probably none based on study that being published and been showed. So it's a class effect for now for these two. You can use either DAPA or EMPA. Okay, safety profile, they both safe and they're both effective in terms of treatment. Just in EMPA, so they use patient with EGFR, they exclude patient less than EGFR less 20. In DAPA, they exclude less than 30. So perhaps maybe those between 20 and 30 EGFR, you might want to use empagliflozin because those are the type of patient that they include in the studies.
The next question. Okay, any concern of risk of GMI and DKA using SGLT2 in heart failure patient without diabetes mellitus? So what's GMI?
Maybe the question need to address what is the exact.
What is exactly the point? Never mind. We go there. Maybe the
cardiology, that would be a global market.
Okay, but okay, we go to fifth question. When will the SGLT2 be indicated for non-diabetic patient? Oh, with heart failure in Malaysia. When? Okay, Patrick, what do you think?
I think eventually, I believe in the next year, ESC is going to launch a new guideline, mainly because of this SGLT clinical trial. I think when more and more guideline has came, so I believe in Asia or in Malaysia, again, there were high chances that revise the guideline to approve the use of SGLT2 in heart failure patient without diabetes, right? I believe.
In fact, there's also a studies going on called empatropism. They're looking at patients without diabetes. You've seen the EMPEROR reduce, they include both diabetes and non-diabetes, but they also have study ongoing, just looking at patients with non-diabetic.
Golden question, number 6. How will you position SGLT2